My name is Khaldoon Alaswad. I'm the Cath Lab Director at Henry Ford Hospital, and I'm here today to speak to you about percutaneous coronary intervention versus coronary artery bypass grafting in multivessel disease with a chronic total occlusion. Certainly, the field of percutaneous revascularization has been progressing most recently with the advent of a third-generation drug-eluting stent. Multiple data now exist that showed that the current technology supersedes the old technology by far, much better even than the first-generation drug-eluting stents. And percutaneous coronary intervention was compared in several studies to coronary artery bypass surgery, and most of the time the percutaneous coronary intervention was inferior to coronary artery bypass surgery. However, there are important points to remember. Most of the trials were comparing PCI versus CABG are older than the current technology, medical therapy, and even the skill sets of the interventional cardiologists nowadays. And we have to remember also that target vessel revascularization in these trials, which could be done on an outpatient basis nowadays, was counted as bad as death, myocardial infarction, or strokes in these trials. Third, immediate and long-term SVG patency has been shown repeatedly to be poor, especially in patients with CTO, as I will demonstrate later in this talk. The fourth point, there was no superiority of CABG over PCI when it comes to the death, myocardial infarction, or stroke composite endpoint in most of these trials. And most importantly, and this is the last point here, that the gap in revascularization rate, which is usually demonstrated as superior in CABG versus PCI, this gap has been closing progressively since the advent of balloon angioplasty, and now we are in the third generation drug-eluting stents. I like to warn the audience to one fact that when you look at coronary angiography, you have to remember that not all stenoses might be significant. And this is the difference between functional revascularization versus anatomic revascularization. We used to estimate the stenosis by 70% stenosis, and every 70% stenosis or 50% stenosis would require revascularization. However, with the use of functional revascularization, we found out that we use less stenting. If you perform functional flow reserve in patients with a three-vessel coronary artery disease or multivessel coronary artery disease, you actually discover a lot of those patients at the end of the day don't have severe three-vessel coronary artery disease. They might become two-vessel coronary artery disease or single-vessel coronary artery disease. And as demonstrated in this slide, only 14% actually has functionally three-vessel severe stenoses. And not surprising that 9% of those patients actually have no significant stenosis, although the angiographer thought those patients have a three-vessel coronary artery disease by angiography. So we have to be more vigilant in obtaining angiography and obtaining functional measurement of the severity of the stenosis. So back again to coronary artery bypass surgery versus PCI. As you know, PCI is counted as a disruptive technology. We started way after coronary artery bypass surgery, and we've been growing together. So I would like to point out, and these two guys now, the coronary artery bypass surgery will definitely win or won in the past. However, as we grow older, things might change as those two guys might meet in the future, or they already are meeting now. Let's analyze the Syntax trial. And as it said, the devil in the details. So this is the Syntax trial, as you remember, finished around 2005, 2007, and it was reported and it showed difference between PCI and CABG in favor of CABG. And the Syntax score, which measures the complexity of the coronary artery disease, was actually very telling here. So if the coronary artery disease is very, very complex, as measured by Syntax score above 32, coronary artery bypass surgery performed better than PCI. However, let's look close at the data. These groups are actually divided into the overall cohort. In the left column A here, column B is only the left main cohort, and column C here, the 3-vessel disease. So let's concentrate on the subgroup analysis in this trial. If you notice here, the left main coronary artery disease, when the syntax scored less than 32 or less in these two groups in the left side here, there was not much difference between PCI and CABG. And the same goes for coronary artery bypass surgery in multivessel disease. When the syntax score was less than 22, there was not much difference between the PCI and CABG. However, I'd like to remind you that this trial is actually old by the current standards. This trial used the Taxus stent, which is the first generation drug-eluting stent, which shown in multiple studies that it's inferior to the current generation drug-eluting stents. I'd like to remind you too that the scale sets has changed since then. The interventional cardiologists in these trials, in this trial, were able to revascularize the CTO, for instance, in less than 50% of the time, while the surgeon revascularized the chronically occluded vessel more than that. However, the skill sets progressed significantly, as we'll demonstrate in the next few slides. Overall, 43% of the trial cohort they would have done equally good with PCI versus CABG. So if you look at actually now the syntax 2, which here measures not only anatomical factors and angiographic factors, also factors in the age, the creatinine clearance, the ejection fraction, gender, COPD, and peripheral vascular disease. And if you look at this graph here, everything falls to the left of this line. If it's a dark color, that's actually clearly this patient favors CABG. Everything falls to the right of this line here. That means if it's a dark color, that favors PCI. And this is factoring in the anatomic factors in addition to other clinical factors, as we mentioned. So if you look here, the decision is not really clear. If you notice, there are a lot of gray colors here in the middle. When we factored in clinical factors, these gray colors, actually there was the syntax score and syntax 2 score was not able to determine which is better, is it CABG or PCI. And this is here in the left main group. This is here in the 3-vessel disease group. There is clearly more patient on the left side. That means CABG is more. There are a few patients or a few group of patients on the right side. That means PCI more. But in the gray side, in the gray zone here, there is also a large cohort of patients, and that goes with all subgroup analysis in this. So the decision is not a black and white anymore, and it's not easy. And several other factors have to be weighed in by the heart team to decide if the patient needs a PCI or CABG. So let's say the patient actually was accepted or determined by the heart team to go to CABG. Unfortunately, the surgeons were only bypassing the CTO in 68.1% of the time. So the chronically occluded vessel did not receive a graft in about 32% of the time, and that's considered failed to revascularize chronic total occlusion by the surgeons. While PCI fails only in 10% of the time in specialized centers. So the current skill sets and the technology is able to perform successful CTO PCI in 90% of the time. There is another point is shown by this slide. This comparing patients before that had CABG versus patients who did not have CABG before the CTO PCI. And if you notice, the success rate in those patients who had received CABG before the CTO PCI is less than patients who never had surgery. So the coronary artery bypass surgery makes PCI more difficult. And this is the concept of burning bridges, which we will talk about later. So we talked about in the syntax trial that only 68% of the CTO vessels received bypass graft. Now let's talk about the patency of those bypass graft. This is the Prague 4 trial. This is a study published in the early 2000s and looked at the patency rate of an SVG at 1 year. They performed surveillance angiography in every patient. There was 255 patients involved, included in this, and there are about 4 to 5 surgeons, and these surgeons were the best surgeons in Europe. Each one of them performed between 150 to 200 coronary artery bypass surgery a year. And if you look here, they did these surgeries on pump and off pump, and if you look, the patency rate on pump is 59% at 1 year for the SVGs, where the Lima actually had a much better patency rate, but it's not 100% either, it's 91%. When you look in the subgroup of patient who had CTOs, if the bypass was attached to CTO, the patency rate was at 24%. And in the vessel, other vessel was 22%. The only time the bypass actually was effective when the CTO was in the LAD. So if you have a CTO in the RCA, if you have a CTO in the left circumflex, the 1 year patency rate of the SVG was only about 23% at the best. So let's move on to look at the data comparing PCI versus CABG in more contemporary literature. So this is a registry data from New York State. They included 9,223 matched pairs of patients. And this is not a prospective study. This is a registry data, but it has a large number of patients, and compared PCI using a everolimus-eluting stent, which is now considered the second generation drug-eluting stent, to bypass surgery for multivessel coronary artery disease. The study was performed by Dr. Shripal Bangalore and his group from NYU. Let's look at the results of this. If you look here in the upper left side under A, this is death. PCI and CABG, they were equal. The p-value is 0.5. There was no difference between PCI and CABG and death. If you look at the column at B here, the PCI group had increased myocardial infarction. Look across from that to C, while the CABG group have increased stroke incidence. Of course, target vessel revascularization in PCI, or revascularization in general in PCI, was worse than CABG. But let's look also at the details and subgroup in these patients. When Dr. Bangalore and his group looked at patients who received complete revascularization with PCI and compared those to CABG patients, here on the left side, the myocardial infarction was not different. So the secret was actually in performing complete revascularization. Unfortunately, when you performed incomplete revascularization, the myocardial infarction in the PCI group was increased. And this is another point we can argue in a different talk about the importance of complete revascularization, and we'll come to that again in the next few slides. In conclusion, Dr. Bangalore and his group concluded that there was no increased risk of death in PCI versus CABG. CABG was associated with higher risk of stroke. PCI was associated with higher risk of myocardial infarction among patients who with incomplete revascularization, and repeat revascularization was increased with PCI. This is the latest trial comparing coronary artery bypass surgery to PCI. It's called the BEST trial, performed in Asia by Dr. Park and his group. This enrolled about 800 patients. This trial actually was halted before the completion. The intended number was about 1,700, but there was a slow enrollment. The authors of this article attribute that slow enrollment to the advent of FFR and difficulty of finding patients to enroll with a 3-vessel disease. But I'd like to point out here, if you look in the coronary artery bypass group, The patient received on an average 3 grafts. 2 of those grafts were arterial. So this is actually very, very good surgery. At the end, there was 71.5% complete revascularization in the surgery group, while the PCI group only 50.9% complete revascularization, which will affect the result of this trial. These are the outcomes. Here we're comparing in A, we're comparing death, MI, and target vessel revascularization. PCI was inferior with a p-value 0.04. If you compare in B here, death, myocardial infarction, stroke, or repeat revascularization, we added stroke and any repeat revascularization, PCI also performed inferior. But let's look at the details of this study. And this is comparing each endpoint individually. This is death. There was no difference between PCI and CABG, and the p-value was 0.3. This is overall myocardial infarction. There was also no difference. The p-value was 0.9. This is a composite endpoint of death or myocardial infarction or stroke. Also, there was no difference. The main difference was in repeat revascularization, and the p-value was actually significant, 0.003. Let's look in the subgroup of that. And when you look at target lesion revascularization, meaning the stent area revascularization, there was actually no difference. So as you remember, the SVG bypasses the first 7 centimeter of the coronary artery, and this is where most plaques rupture happens. So when you spot stent an artery, you leave another 3 or 4 centimeter for another plaque rupture to happen down the road, which probably could argue, some will argue that we should use long stents all the time, but this is a different subject. So again, in the BEST trial, the difference was in repeat revascularization. In an editorial in the same journal, in the New England Journal of Medicine, the authors lamented that it could be also complete revascularization that caused increased events of repeat revascularization in the PCI group. In the BEST trial, they looked at the subgroup analysis to see which is best in the subgroup analysis, PCI versus CABG. And if you notice here, CABG on the right, if the dark square falls on the right side without crossing unity line, that means CABG is clearly better. If it's on the left side, that means PCI is better. If you notice, all these dark squares cross the unity line except in the diabetic patient. And this takes us back to the FREEDOM study that showed in diabetics, the CABG is clearly superior to PCI. Any other subgroup here, including age, sex of the patient, acute coronary syndrome, yes or no, ejection fraction above 40%, less than 40%, number of vessels, 2 or 3, syntax score above 33, 23 to 22, less than 22, and even the Euro score, when the Euro scored less than 6 and above 6, it did not make a lot of difference. And that actually contradicts the syntax score when in the syntax trial, when the patient had increased complexity of their coronary artery disease, there was a clear benefit of CABG versus PCI. In this trial, there wasn't a clear benefit. And this could reflect just how the technology has advanced since the syntax trial finished in 2005. This BEST trial is performed more recent and published just recently, and that reflects our advance in skills and technology in the interventional cardiology world. And again, we alluded to this. In the BEST trial, 71.5% of the patient received a complete revascularization in the coronary artery bypass graft arm versus only about 51% in the PCI, and that could be responsible for the difference in complete revascularization rate in the PCI. So we're going to go over hypothetical scenario here in this illustration to illustrate to you What will happen in patient with multivessel disease, one of them has a CTO, if we send them to surgery? It says 100 patient with CTO. If you send them to coronary artery bypass surgery, about 68% of them will receive coronary bypass graft to the CTO vessel, where about 32% will not. If you factor in the patency rate of the graft, 23% patency rate, after 1 year, it will be 16% patent grafted vessels in 1 year. Only 16% in 1 year. Now let's use the same scenario in PCI. This is a 100 patient with multivessel disease, add a CTO, you send them to PCI. So there will be about 90% successful CTO PCI revascularization in the specialized centers. So only 10% of those patients will receive incomplete revascularization to the CTO, granting that the interventional cardiologist performed complete revascularization in all other vessels. If you look at the patency rate post CTO PCI at 1 year, there is 11% target vessel failure. So at 1 year, there will be 79% of those vessels had a CTO are patent. Much better than this 16% with CABG. This is hypothetical and it's contingent on a heart team approach and an availability of a technology and skills in the specialized centers for CTO. Again, you have to remember that native coronary arteries are more difficult to treat after coronary artery bypass surgery, and this has been shown in multiple studies. This is another hypothetical patient. Most patients who are 60 years old, if you send them for coronary artery bypass surgery, according to the patency rate of the SVG, they will outlive their SVG. And the treatment of those patients will be much more difficult post-CABG as opposed if they were CABG naive with PCI. This reflects the advancement in the outcome of PCI. If we compare back in balloon angioplasty, the difference in risk reduction is decreasing. So risk reduction, mortality risk reduction with PCI versus CABG was 45% in the balloon angioplasty era. When we went to bare metal stent, went down to 30%. In the first generation drug-eluting stents, so it's a Cypher and a Taxus stent, went down to 24%. And according to the Bangalore paper from New York, and according to the BEST trial, now the risk reduction in CABG versus PCI is 0%. There is no more mortality benefit to CABG over PCI. Let's look at revascularization rate. This is also the same thing. Here, the balloon angioplasty era, and 37%. By bare metal stent decreased to 35%. First generation drug-eluting stent went to 30%, and second generation drug-eluting stent is 19.4%. And now we have the approval of the biodegradable stent and biodegradable polymer, which could be counted as a third generation drug-eluting stent. That could even decrease this number even farther. At the end of the day, this should be a patient-centered approach, and the decision should be made by the heart team with the patient wishes, culture, and well-being at the center of their decision. And we should listen to our patient. More and more patients actually refusing the aggressive coronary artery bypass surgery. And this is the story of the PCI. We have continuous progression and development in the stent technology. The success rate in CTO PCI improved, as shown in this graph by Brilakis and his group, while the MACE rate, or major adverse event of the procedure, is actually decreasing significantly. Now we have improved medical therapy post-PCI. We have the new generation of platelet inhibitors, and we have more risk factors control. All this will culminate in improved outcome of PCI versus CABG. At the end of the day, it's a heart team approach that should include the interventional cardiologist, the general cardiologist, and the surgeon, and most importantly, include the patient and their family. Thank you.